Jones. I'm a clinical psychologist and the Associate Clinical Director for the Louisiana's Office for Citizens with Developmental Disabilities. Today, I'd like to talk a little bit about the applicability of cognitive behavioral therapy, or CBT, for individuals with intellectual and developmental disabilities, or IDD, including autism. I'd like to start off with this basic fact. First-line treatments work for most individuals. This is easy to understand when we talk about medical health treatment, but it also applies to mental health treatment too. Albeit some personalization will be needed. Just like with medical health, where it's the case that not everyone receives the same dose of medication, the physician may account for age or weight or tolerance of the side effects. What I'd like you to know is that the applicability of cognitive behavioral therapy for people with IDD just needs a few modifications to personalize it and make it effective for a person with IDD. And you may find that some of these modifications would and could be used for your folks without IDD too. There are specific modifications that can be implemented to assist your client in identifying and labeling thoughts, emotions, distorted thinking, and other aspects of CBT. These modifications to CBT can be implemented while maintaining adherence to the core CBT model. Let's consider the basic concept of CBT, that thoughts, emotions, and behaviors are interrelated and each one affects and is affected by the others. Building the therapeutic alliance and setting the goals and expectations for the therapy process often starts with an explanation of CBT. Here, clients buy in to the CBT process as they begin to understand and experience the process. This is equally true for a person with IDD. Demystifying the process and making it understandable will increase their belief in the effectiveness of the process. Simplifying the description of the CBT process will facilitate understanding. Using a phrase like "thoughts change feelings" can assist the person in grasping the basic concept. To communicate this idea, follow this basic pattern. First, engage the person and ask them to think of a happy memory. Then ask how the memory makes them feel. Second, repeat this exercise with a sad memory and a memory of an event that resulted in anger. Ask the person if thinking of these memories changed the way they felt. It may be necessary to use multiple memories and to repeat this exercise at the beginning of several sessions to remind the person of the process. Once a person has an understanding of the basic concept of CBT, the next concept is identifying patterns of negative thinking and linking that to the associated emotions and behaviors such as sadness, hopelessness, depressed mood, or social withdrawal. In general, we want to take these abstract concepts and give concrete examples and simple phrases to remember. The therapist can demonstrate this connection by saying, "I will think about a happy memory and describe how I feel." When engaging the client to do this, identifying and labeling thoughts and emotions, use specific examples that the person has mentioned. Use these tips to modify your approach. First, to identify the emotion, encourage the person to use their examples, those they have already shared, even if the identification is basic, feel good versus feel bad. Second, use simple, easy to remember phrases similar to "think happy, feel happy," and "think sad, feel sad," to help the person connect their thoughts to their emotions and behaviors. In making these minor modifications, we have reframed the abstract concept of identifying and labeling patterns of negative thinking to simple, easy to remember phrases that have provided concrete demonstrations and have engaged the client in these exercises through the use of their own specific examples. Another core concept of CBT is labeling distorted thinking, such as fortune telling or disqualifying the positive. Labeling types of distorted thinking can be a tool for the client and facilitates discussion and analysis of typical patterns. For people with IDD, it can be beneficial to omit these abstract labels and focus on identifying the thoughts. Use these tips to alter this component of the CBT process. Rather than categorizing the pattern as, for example, discounting the positive, focus on identifying and labeling the thoughts as sad thoughts, angry thoughts, positive thoughts, or negative thoughts. As patterns of distorted thinking emerge, rather than labeling the pattern, describe the pattern. For example, say, "John, you appear to be thinking about the sad parts only." Third, use multiple examples over multiple sessions to describe the pattern using specific examples in the client's words. Remember, the important aspect is not placing an abstract label on the pattern of distorted thoughts. The key is being able to identify the thought, sad, negative, happy, and link the thought to their emotional state and behavior. A core active treatment component of CBT is countering or challenging negative thoughts and using positive thinking against negative thoughts. Teaching a person the skill of saying and thinking positive things when negative thoughts arise is the central aspect of CBT. Teaching this skill will require modification and adaptations to facilitate learning and retention of the skill. As touched on in another module, there are numerous common adaptations when teaching skills to people with IDD. First, simplify your language. Be aware of the language and terminology being used. Is there a simpler way to describe it? Is there simpler, more concrete language that can be used? Second, model the skills. The therapist or a caregiver should model the skills before asking the client to demonstrate the skills. When correction or guidance is needed, model the difference between what the client demonstrated and the expectation so the client can see the difference. Third, repetition. Everyone benefits from repetition. This is especially true for people with IDD. The repetition should occur within the session, but also over multiple sessions to ensure that the learned skills does not fade over time. Fourth, massed practice. Once is never enough. For learning and retention of the skill, multiple sequential practices are necessary. Fifth, shaping. Close is good enough at first. A skill or an aspect of a skill that you typically teach in one step may need to be broken down into multiple steps. Assess what was done correctly and what could use additional guidance or improvement. Provide the guidance and try again, slowly guiding the responses to the desired target skill. Sixth, positive guidance and feedback. Feedback is essential to learning any skill. Providing positive guidance and reflection is essential to making the learning process more effective, efficient, and enjoyable. This is especially true when working with a person who knows they struggle to learn new skills or material. Positive reinforcement and positive assurance help ensure motivation and, more importantly, belief in their ability to master the skill. Seventh, extra reinforcement. Positive thinking can be self-reinforcing. At the beginning of treatment, however, copious praise and social reinforcement may be required to jumpstart the use of the skill. Finally, booster sessions. For some people with IDD, booster sessions may be necessary to ensure long-term retention of the learned skills. If there are available caregivers, they could ensure regular practice and reinforcement of the learned skills. Also, a scheduled booster session with the therapist at a predetermined time to ensure mastery may be warranted. We just reviewed several key tips for teaching an individual with IDD the core concept of CBT, to replace negative thinking with positive thinking to moderate negative emotions. Let's do a quick summary. 1. Simplified language. 2. Model the skills. 3. Repeat frequently. 4. Build in massed practice. 5. Remember shaping is an okay approach. 6. Positive guidance and feedback. 7. Enhance positive feedback in early sessions. And 8. Plan for a booster session. Which of these you decide to use will be individualized to the person and their needs. Getting to know the person first is essential to making modifications. And remember that not everyone will need modifications just because they have an IDD, and even those who do need modifications will not need the exact same modifications. It's also important to remember that individuals with IDD often rely on others for support on a day-to-day basis. As you are teaching these CBT skills, you will need to consider the importance of including these supporters in sessions, as well as providing any needed guidance on how they can support the person to practice these skills outside of the session. These simple, common teaching adaptations can be implemented and incorporated into all aspects of the CBT process to maximize learning and retention of skills. Of note, some people with IDD rely on family, friends, paid support workers, or other caregivers to assist in their daily lives. The therapist will need to consider if and when to include this support system in the formal therapy process. Obviously, the inclusion of any caregivers and the degree to which they are included should be at the discretion of the client and granted by informed consent. These caregivers can serve several functions. They can provide reminders. Caregivers can remind clients to utilize the skills learned in session, including using new language and concepts taught. Reinforcement. Caregivers provide additional positive reinforcement to the client between sessions. Coaching. Caregivers can be taught to provide feedback and coaching on new skills. Homework and logs. If the client experienced difficulty writing or typing, the caregiver can assist with homework or logs such as mood logs or sleep logs. People with IDD experience behavioral health issues at rates higher than the general population. They benefit from the same evidence-based therapeutic interventions such as CBT and DBT, which are used for people without IDD. The provision of CBT for people with IDD is not related to a niche area that requires years of specialized training. Rather, it's a cultural competency on the part of the therapist that typically requires only common sense modifications, which do not impact the core values of the intervention. Today, we talked about modifications to core CBT concepts in therapy. There are other modules in this series that may also be helpful for you to view. Thank you for taking the time to listen to this brief presentation.